on inflammatory bowel disease. There are two disorders that fall under the heading of inflammatory bowel disease. One is called Crohn's disease, the other is called ulcerative colitis. Both of these are autoimmune conditions with an unknown trigger, and both are chronic diseases that people will have throughout their lives once they're diagnosed. However, they both have a relapsing remitting course, so patients will be stable for a period of time, or sometimes they're even asymptomatic, and then they will have a flare of symptoms where their medication requirements go up in order to get the disorder back under control. Both of these disorders involve the intestines, and they can have similar symptoms. As I said before, they both have recurrent episodes of symptoms. They can both involve abdominal pain and bloody diarrhea. As we'll talk about throughout this module, there are some symptoms that are more common in one disorder versus the other. However, in general, the symptoms have a lot of overlap. Both forms of inflammatory bowel disease have a slight female predominance in most of the epidemiology studies. The age of onset is usually about 15 to 40 years of age. There are some data that suggest a second spike in incidence in the 50 to 80-year-old age groups. Both disorders are more common among whites and more common among people of Jewish descent. So the classic presentation to know for your boards is a white woman in about her 30s who is of Jewish descent. Before we talk about the two forms of inflammatory bowel disease, let me pause and mention bloody diarrhea. Bloody diarrhea may be a symptom of both Crohn's disease and ulcerative colitis. However, you should know that inflammatory bowel disease is a relatively uncommon cause of bloody diarrhea. There are many other more common causes, especially infection. So when someone presents to their physician complaining of bloody diarrhea, before you consider a diagnosis of Crohn's or ulcerative colitis, you often need to rule out other infectious causes of bloody diarrhea. So often stool cultures are sent to look for Salmonella and Shigella and Campylobacter and Yersinia. All of these bacteria can cause dysentery, which is bloody diarrhea. You often test for the invasive form of E. coli, the 0157 form, because this can cause bloody diarrhea. And other stool studies are also often sent as well, Clostridium difficile and ovin parasites, to look for parasitic infections. Now we'll talk about the two forms of inflammatory bowel disease, and we'll start with ulcerative colitis. And the name of this disorder tells you everything you need to know. It involves ulcers in the intestinal tract, specifically in the colon. That's why it's called colitis. In this disorder, there is autoimmune inflammation of the mucosa and sometimes the submucosa. Very importantly, it is not full thickness inflammation of the GI tract lining. Full thickness inflammation happens in Crohn's disease. So if we look at this picture on the screen, you can see the mucosal layer here. It's the innermost layer. It includes the epithelium, the lamina propria, and the muscularis mucosa. That is involved in ulcerative colitis. So is sometimes the submucosal layer, but importantly, not the muscularis and not the serosa. Ulcerative colitis always starts in the rectum and works its way upward. This disorder always has rectal involvement, and for that reason, left lower quadrant pain is a common symptom. That's because the rectum and the most distal portions of the colon are in the left lower quadrant. Importantly, ulcerative colitis never involves the small intestine. As I told you before, the name tells you everything you need to know, and in the name is the word colitis, and colitis refers to the colon, not the small intestine. There are several classic gross morphology features of ulcerative colitis that you should know for step one, and the first is the presence of pseudopolyps. These result from the healing of ulcers. To understand this, imagine that we have an ulcer in the lining of the GI tract and then the ulcer heals. The scar tissue that is laid down can be heaped up and can create a raised portion above the normal mucosa, and that can give the appearance of a polyp. Shown on the screen is a colon specimen from a patient with severe ulcerative colitis, and you can see numerous polyps. These are the result of scar tissue from the healing of ulcers. A second classic feature of ulcerative colitis when you look at the colon grossly is the loss of haustra that leads to a lead pipe appearance on imaging. This is a 3D reconstructed image from a CAT scan of a patient who had ulcerative colitis. If you look at the ascending colon here, you see the normal haustra, which are these pouches of the colon. However, if you look at the descending colon here, you can see that the haustra are missing, and they've gone missing because of the inflammation from ulcerative colitis. This gives the intestine the appearance of a straight or lead pipe, hence it is called the lead pipe appearance of the colon on X-ray or CAT scan. The classic finding of ulcerative colitis on microscopy when you look at biopsy specimens is the presence of crypt abscesses. These are neutrophils that have infiltrated the crypts. If you look at the specimen on the right side of the screen, you can see that there are lots of neutrophils infiltrating the mucosa of the colon. If you look at the picture on the left, we're looking down on the crypts, and this one in the middle of the screen is filled with cells. Those cells are neutrophils. They have filled the crypt and are forming an abscess inside the crypts of the colon. There are a number of extraintestinal features of ulcerative colitis. Just like inflammation occurs in the colon in this disorder, it can also occur elsewhere. One place is in the skin. In ulcerative colitis, patients can develop pyoderma gangrenosum. This is a picture of pyoderma gangrenosum on the screen here. You can see that it's an ulcer in this patient's skin. And just like the disorder causes ulcers in the colon, it can also cause ulcers in the skin. It's a deep necrotic skin ulceration. A second extraintestinal feature is primary sclerosing cholangitis. I talk about this in detail in the module on biliary disorders. This is a biliary disorder where strictures form in the bile tree, and this generally only occurs in patients with ulcerative colitis. It's very rare outside of patients with ulcerative colitis. Another extraintestinal feature is ankylosing spondylitis. This is inflammation of the spine that will lead to back pain. And finally, patients can have inflammation in the eye. They can develop uveitis, which is inflammation of the middle layer of the eye. And an easy way to remember this is to just understand that a number of different autoimmune disorders cause inflammation of the uvea. Rheumatoid arthritis can also do this just like UC. A feared complication of ulcerative colitis is called toxic megacolon. This used to be believed to be a complication that only occurred in patients with UC, although it's now recognized that it can also occur in some forms of infectious colitis. What happens in toxic megacolon is that for reasons that are poorly understood, the colon stops contracting. There's evidence that nitric oxide is synthesized and released, and that this inhibits the smooth muscle tone in the colon. The result is rapid intestinal dilation, and the walls can thin and they are prone to rupture. And the feared complication of toxic megacolon is perforation. Patients with UC can die if they develop this complication and perforate their colon. The presentation will be a patient with known ulcerative colitis who develops abdominal pain, abdominal distension, fever, diarrhea, and shock. The word toxic is in the name of the disorder because of the fever and shock. There are other forms of bowel obstruction that can lead to abdominal pain and distension, but the patient won't be toxic. If they are toxic and in shock, then you need to think of this diagnosis. The diagnosis is made by obtaining a flat plate X-ray of the abdomen. You will see large dilated loops of bowel as shown in this example on the screen. Ulcerative colitis carries a significant risk of adenocarcinoma of the colon. However, the risk is not the same for all patients with UC. You need to have the disease for at least 10 years for most cancers to form, so patients are at low risk when they are first diagnosed, but they are at greater risk once they've had the disease for a long time. The more of your colon that is involved, the more the risk. So if it has extended from the rectum all the way into the right colon or the ascending colon, that means patients have more disease. Remember that UC always starts in the rectum and then goes backwards through the colon. So if you have right-sided colitis or pancolitis, these are important risk factors for the development of adenocarcinoma. Screening colonoscopy is often done on patients with ulcerative colitis, especially after they've had it for more than 10 years. Multiple biopsies are usually taken to look for early development of cancer, and colectomy is sometimes required when patients start to develop cancer cells, especially if they develop them at multiple sites. The diagnosis of inflammatory bowel disease is often made by doing a colonoscopy or an endoscopy and taking a biopsy of the inflamed mucosa. However, there are some antibody tests that are sometimes used. The first one is the p-ANCA antibody. I talk about this antibody in more detail in the vasculitis module because it's abnormal in several vasculitis syndromes, including Churg-Strauss and microscopic polyangiitis. However, elevated levels of the p-ANCA antibody are also seen in ulcerative colitis. There is another antibody called anti-Saccharomyces cerevisiae antibodies. Saccharomyces cerevisiae is a type of yeast. If you've ever baked bread or better yet brewed beer, this is the type of yeast that you use for those purposes. Antibodies against this yeast are seen in Crohn's disease for reasons that are not entirely clear. So both of these tests are sometimes suggested as a way to distinguish the different forms of inflammatory bowel disease. If this were positive, it suggests UC. If this is positive, it suggests Crohn's. However, neither are reliable enough for routine clinical use. Now let's talk about Crohn's disease, and on the screen here I've written some of the very high yield features of Crohn's disease to know for step 1. The first thing to know about Crohn's is that it involves granulomatous inflammation. You will see granulomas in Crohn's disease and you will not see that in ulcerative colitis. Also, in contrast to ulcerative colitis, the entire wall is affected. It's called transmural inflammation. It does not just affect the mucosa and submucosa like ulcerative colitis. And then finally, an important distinction of Crohn's from UC is that in Crohn's, any portion of the GI tract can be affected. Many people say it can affect anywhere from the mouth to anus. Oral ulcers are even sometimes seen. The rectum can be involved, and also the small intestine can be involved. And this distinguishes Crohn's from ulcerative colitis. In ulcerative colitis, it always begins in the rectum and moves backwards through the colon and never involves the small intestine or above. The terminal ileum is a classic location for the inflammation of Crohn's, and this can result in a couple of characteristic clinical features of Crohn's disease. and one is malabsorption. As you may know, vitamin B12 is absorbed in the ileum, so you can develop a B12 deficiency if you have Crohn's. In addition, the ileum is where many bile salts are reabsorbed, so because you cannot reabsorb bile salts, a couple of things can happen. First of all, patients with Crohn's are at increased risk for gallstones because of loss of bile salts. Secondly, the bile salt loss can lead to a secretory diarrhea. It can draw fluid out into the colon. And in addition, the loss of bile salts can lead to malabsorption of fat, so a steatorrhea can occur. And for this reason, many patients with Crohn's have non-bloody diarrhea due to a malabsorption syndrome. Another characteristic clinical feature of Crohn's is right lower quadrant pain, and that's because the terminal ileum is often involved, and the terminal ileum radiates to the right lower quadrant. Other features of Crohn's you should know about are that it often spares the rectum. This is in contrast to ulcerative colitis, and it often skips sections of the GI tract. So remember that ulcerative colitis was continuous. It began in the rectum and went all the way through the colon. In Crohn's disease, the inflammation can skip sections and appear in the ileum, and then in the middle of the colon, and then somewhere else further down the line. Here are two pictures showing some common presentations of Crohn's disease. The picture on the left shows isolated inflammation of the ileum, which is a common presentation. The picture on the right shows inflammation of the ileum and then skip lesions involving other portions of the colon. Importantly, note that the rectum is spared in this picture, and that is typically the case for Crohn's disease. The hallmark on biopsy is presence of granulomas. If you see this, it basically cinches the diagnosis of Crohn's disease because ulcerative colitis will not cause granuloma formation. One of the gross morphology hallmarks of Crohn's disease is the presence of a cobblestone mucosa. This is a picture of cobblestone on the screen here, and the mucosa can begin to look like this. The stones are normal mucosa, and these deep fissures between them are formed by the transmural inflammation of Crohn's disease, leaving these elevated islands of normal mucosa that look like a cobblestone. Another characteristic feature of Crohn's disease is the development of fistulas. Fistulas are a connection between the intestine and some other portion of the body, and they can form between a number of places in Crohn's disease. To understand this, imagine that we have a loop of small bowel that is affected by Crohn's disease. Remember, the disorder affects the entire wall of the intestine, so we have transmural inflammation, and that can spread outside of the wall of the intestine to whatever structures happen to be nearby. If the bladder happens to be nearby, then the inflammation can spread to the wall of the bladder, and a connection can form between the intestines and the bladder. That's called an enterovesical fistula, and that can lead to feces in the urine or air in the urine. If the skin happens to be nearby the loop of bowel, then a fistula can form between the intestines and the skin. This can result in an opening in the wall of the abdomen or an opening near the skin around the anus. And I've summarized these points in this slide here. So perianal fistulas are common, so are abdominal fistulas, and rarely patients can get a fistula with the bladder called an enterovesical fistula. Two other features of Crohn's disease are the presence of creeping fat and the presence of strictures. Creeping fat occurs because transmural inflammation heals and the condensed fibrous tissue pulls the fat around the bowel wall. So the intestine of a patient with Crohn's disease will have fat wrapped entirely around the bowel. Normally you have loops of bowel like I've shown here with a small amount of mesentery and fat in between them. In patients with Crohn's disease, this fat extends and surrounds both loops of bowel. That's called creeping fat, and that's a result of the transmural inflammation of the disorder that leads to pulling the fat around the entire intestine. Strictures are narrowing of the intestinal lumen that occurs as a result of healing, which deposits fibrous tissue, and dense fibrous tissue can narrow the lumen. This can result in a radiology finding called the string sign. To understand the string sign, imagine that we give oral barium to a patient with Crohn's disease. They'll drink the barium, it will fill their intestines, and then we can take an x-ray of their abdomen. The white barium will fill normal portions of the intestine, and they will appear normal in the x-ray. However, when the barium reaches a portion of the intestine like the ileum that is commonly affected by Crohn's disease, the barium will narrow down to a string of barium. That's called the string sign, and that occurs because of the strictures that are characteristic of Crohn's disease. I told you before that adenocarcinoma of the colon is a significant risk in patients with ulcerative colitis. That is true in Crohn's disease only when the colon is involved. When patients with Crohn's have colon involvement, they generally undergo surveillance colonoscopy just like UC patients. However, if the inflammation is limited to the ileum, the risk of adenocarcinoma is generally not increased. There are several extra intestinal features of Crohn's disease, just like there were for ulcerative colitis. The inflammation can spread to other parts of the body. One characteristic feature is migratory polyarthritis. This is the most common extraintestinal manifestation of Crohn's. It involves arthritis of the large joints, especially the knees and hips. So if a patient presents with abdominal symptoms and bloody diarrhea and migratory polyarthritis, you should think of Crohn's disease. Another extraintestinal feature is erythema nodosum. This is inflammation of the fat under the skin. This is a picture of it on the screen here. It results in red, painful splotches on the shins usually. Patients with Crohn's disease have increased rate of development of calcium oxalate kidney stones, and the reason is because of the high oxalate levels seen among patients with Crohn's. As I told you before, Crohn's can involve the terminal ileum, and this can lead to fat malabsorption. All that fat that is left behind in the gut tends to bind calcium. This leaves oxalate free, unbound from calcium, to be absorbed by the gut at higher rates compared to normal subjects. As a result, there is more oxalate present in the serum and urine of patients with Crohn's, and they have an increased rate of development of calcium oxalate stones. Patients with Crohn's also can develop ankylosing spondylitis and uveitis, just like patients with UC. These two extraintestinal features are seen in both UC and Crohn's. It's very high yield for step 1 to know how the T cell responses differ between ulcerative colitis and Crohn's disease. T cells are a major contributor to both disorders. However, in ulcerative colitis, it is largely a Th2-mediated response. And if you've watched the immunology module on T cells, that should make sense to you because there are no granulomas in ulcerative colitis, and a Th2 response is generally not associated with granuloma formation. Crohn's disease, on the other hand, is largely a Th1-mediated disorder. Th1 disorders, as you know, are cell-mediated, and therefore it should make sense to you that Crohn's disease results in formation of granulomas. For reasons that aren't well understood, smoking affects both forms of inflammatory bowel disease. However, it affects them differently. Patients with ulcerative colitis who smoke tend to have better outcomes. On the other hand, patients with Crohn's who smoke tend to have worse outcomes. Patients with Crohn's who smoke can sometimes trigger a flare, and they can end up in the hospital with a bout of bloody diarrhea because they were smoking cigarettes. Many different immunosuppressive drugs are used to treat inflammatory bowel disease. One of the most common is corticosteroids for flares, and then all of these drugs shown on the screen can be used to keep the disorder in remission. I talk about how these drugs work in detail in the immunology module on immunosuppressants. However, I'm going to discuss just these last two on the slide here because they are especially useful drugs in treatment of inflammatory bowel disease. Shown at the top of the screen is the structure of sulfasalazine, which can be used for the treatment of inflammatory bowel disease. When this molecule reaches the colon, colonic bacteria will split it into a molecule of sulfapyridine and another molecule called 5-amino-salicylic acid, or 5-ASA. Now you may know that aspirin is acetylsalicylic acid, so 5-ASA has a very similar structure to aspirin, and it works just like aspirin. This makes this a very useful drug for ulcerative colitis because it is not going to be active until it reaches the colon. It will move all the way through the intestines, and when it gets to the colon, those bacteria will split it and generate the active component, which will then suppress inflammation in the mucosa of the colon. It makes it a very useful drug for treatment of ulcerative colitis or Crohn's disease with colon involvement. It has a couple of side effects you should know about. First of all, it can cause GI upset like nausea and vomiting. The sulfonamide portion of the drug can cause a hypersensitivity reaction in patients who are allergic to sulfa drugs. And then finally, it can cause oligospermia in men. The mechanism is not clear. However, the sperm count comes back up when you stop the drug, and this is a big problem for men trying to conceive on therapy. Remember that this disorder often affects people in their 20s, 30s, and 40s. That may include men who are trying to conceive, and if they are taking this drug to suppress their ulcerative colitis, they are going to have problems having a baby. And I've shown you a picture of some sperm on the screen here to remind you of this side effect of the drug. You can administer 5-ASA by itself, not connected to a larger molecule. That's called mesalamine. And the reason for doing this is because many of the side effects of sulfasalazine are due to the sulfa component of the drug. So if you take sulfasalazine and you remove the sulfa moiety, you are left with 5-ASA, which you can administer by itself. The problem is that much of it is absorbed in the jejunum. Remember that I told you that sulfasalazine works its way all the way to the colon, and then it gets split by colonic bacteria. When you administer 5-ASA by itself, much of it often gets absorbed before it reaches the ileum in the colon, where inflammatory bowel disease is often taking place. So there's less delivery to the colon. For this reason, there are commercially available modified 5-ASA compounds that resist absorption until they reach the distal small intestine or the colon. They usually have a coating or some type of delayed release capsule, and these are drugs like Azicol and Pentasa. They are versions of 5-ASA that are coated, so they will hopefully reach the ileum and the colon. And that concludes our module on inflammatory